Today we are talking about a disease that can occur in the stomach and intestinal area. Unlike colon cancer or stomach cancer, however, it is little or hardly known. This disease is called GIST. Of course, this is an abbreviation, and GIST is also one of the sarcomas. And that's why today we are talking to Dr. Falkenhorst about GIST. You work as an oncologist here at the Sarcoma Center at Essen University Hospital, and you also conduct research on the topic of GIST. It's truly wonderful to have you here today. My first question is, could we briefly go over what the name actually refers to? GIST? What does GIST stand for?
Right. GIST are gastrointestinal stromal tumors, a relatively young tumor type, actually only described since 1998. Previously, they were considered leiomyosarcoma or other tumors of the gastrointestinal tract, until it was discovered that they behave quite differently from other tumors. So GIST stands for gastrointestinal, which refers to the digestive tract. Stroma, that is the connective or supporting tissue that lies between the tissues that perform a function. And that also kind of explains where this tumor is located. It doesn't grow into the organs, but rather between the organs, or actually from the organ into the area between the stomach or intestinal loops and tumor. So it's a malignant disease in the gastrointestinal tract.
And now we've already talked a lot about sarcomas in other videos and repeatedly emphasized that it's so important to go to a sarcoma center, to specialized centers. And now I'm wondering, of course, and patients are probably wondering this too, is a sarcoma center then always automatically specialized for GIST, or is that something else entirely?
I would say that this is quite different, because GIST is indeed a very, very specific disease, because they carry genetic changes that ensure these tumors are not treated with chemotherapy, but with targeted therapy. And this is simply a completely different treatment structure. And since many other sarcomas, for example, occur in the extremities or in the bones, here we are simply dealing with a different area of the body. This means sarcoma centers are committed to treating patients by guidelines. There is the German, so-called S3 guideline, which also includes gastrointestinal stromal tumors. This means every sarcoma center will treat patients based on this guideline. But not every sarcoma center sees the same number of patients with gastrointestinal stromal tumors, but it's important to go to a place where these tumors are frequently seen.
I've brought along an image with me now, you see. So, where exactly can one find GIST in the body? Where would it typically tend to appear?
Right. So GIST is actually found in this area, that is, in the gastrointestinal tract. The tumors themselves, the primary tumors, occur mainly in the stomach. It's found here, but also in the duodenum and small intestine. That is the second most common site, and they are less often found in the rectum, or the terminal bowel, or in the lower esophagus. So that's where the primary tumors are found, while metastases are actually found mainly in the liver or between the intestinal loops in the peritoneum.
What's the difference between bowel cancer and GIST?
The difference lies in the cell of origin. So, classic colon cancer would be a carcinoma, a tumor that originates from the mucous membrane. That's the area we see up here in the picture. That means mucosal cells, just like outer skin cells. These tumors also grow here on top. This means these tumors are often quickly visible on the surface, for example, with an endoscopy. The tumors grow into the bowel, can then also compress the bowel or bleed. These are common complaints that a classic carcinoma causes, and how it would also be found, for example, during a preventive examination, while the gastrointestinal stromal tumors originate a layer deeper. So here we have the area where the muscles are located that ensure the stool or even the stomach contents are transported further. And these muscles are driven by nerve cells that initiate these movements. And they also have this KIT mutation, this typical change that we actually see later in gastrointestinal stromal tumors. This means the tumor develops here in this layer under the mucosa, which, as we see here, is relatively thick. This means this tumor grows more outward. There's less resistance here, one could say, meaning it doesn't grow inward so quickly, but only once it's already quite large. It then grows into that area and can only be seen during an endoscopy.
So, the intestine is, so to speak, a tube, right? And bowel cancer would grow into the tube, but GIST grows, so to speak, on the outside of the tube. Is that how one should imagine it?
Yes, exactly. So it grows in this layer and then tends to grow outwards. But it's not the case that if you looked inside the belly with a camera, you'd automatically always see this tumor from the outside, but it rather pushes the layers apart. Of course, you sometimes really see it lying there on the outside, but that's also a difference compared to a classic carcinoma, that it doesn't grow star-shaped into the surrounding tissue. But in fact, most of these tumors are more spherical in shape. That's another aspect by which you can differentiate it by its appearance.
I've also brought an image of the stomach, and you can see quite similar structures. So here it would be exactly the same, that the stomach cancer, so to speak. Up here, what's this layer called?
That's the mucous membrane layer. The mucous membrane layer, mucosa is the technical term, but we are currently in the submucosa. So, in the area beneath the mucous membrane, where the muscles lie, even in the stomach. And there too, these nerve cells are found, from which GIST tumors probably originate.
We had mentioned, or you had explained, that it tends to grow outwards. Does that then, as a result, cause fewer symptoms than stomach or bowel cancer? Or how is that?
Yes, I think that's generally true. Even classic stomach or bowel cancer can cause symptoms late. But with GIST, it's true. We have a lot of space in the abdomen, unfortunately, and these tumors tend to grow by displacing rather than frequently growing into other structures. And with that, patients often only notice it much later. Unless we truly have this internal connection to the gastrointestinal tract, and it genuinely leads to bleeding, or a tumor ruptures. Or at some point, there's so much tumor that it presses on other structures, causing, for instance, a loss of appetite, or nausea because the stomach lining is affected, or actually blood in the stool. But these are things we usually only see in relatively advanced stages of the disease.
Exactly. So that would have been my question. Does that lead to GIST often being diagnosed late?
It varies. There are patients where it's actually diagnosed quite late, even at a point in time when it has already spread, because, for example, deposits in the peritoneum or in the liver can lead to symptoms earlier. But there are also patients who receive an incidental diagnosis. So, for example, women who went to their gynecologist for a routine checkup decided to have an ultrasound, and then suddenly a lump is found somewhere next to the uterus. These
Oh,
are things that we actually quite often see, where these patients then present to us. Or also, when you have a gastroscopy for other reasons, for example, you have acid reflux or other complaints, and then you suddenly see this bulging into the stomach. So you don't see the tumor itself, but that something is suddenly pushing from the outside. And then you can perform an ultrasound during the gastroscopy, where you actually see that suddenly in this layer, a nodule is found or becomes visible, which you might not have discovered otherwise. So that's also an incidental diagnosis.
are there any concrete warning signs, so to speak, then? So you just highlighted this incidental diagnosis, didn't you? But are there any warning signs that a patient might perceive themselves in their body where one says, oh, this might be a GIST that one should pay attention to?
I find that very difficult to now define concrete things for such an incredibly rare disease. But naturally, in general, the rule is, if you lose weight unintentionally, if you notice your stomach getting hard, or you get stomach pains more often, which you didn't have before, perhaps you don't tolerate certain foods as well anymore, right? You find yourself tightening your belt more and more, even though you're not eating more than usual. Then perhaps one should visit their doctor and say, something feels a bit off. Could you please take a look? And these tumors are often quite hard in their structure, so that even with a more extensive dissemination in the peritoneal cavity, they can often be palpated,
Oh, okay.
if it's very far advanced.
Many people also regularly get preventive checkups. Would a GIST be found then, or not really?
So, if you actually have this bulging, because this tumor is essentially pressing on the mucous membrane from the outside, then an endoscopy could also be beneficial. But GISTs actually occur extremely rarely in the large intestine. In the rectum, it does occur sometimes, but a large part occurs in the small intestine or in the stomach, and these are not the organs where we perform classic preventive screenings. From my own clinical experience, I'd say, if so, it's a gynecological screening with ultrasound where we see it, or a gastroscopy done for other reasons. But there's no screening exam for GIST. The stomach is often air-filled, the bowel is often air-filled. That's an area that can't be optimally examined with ultrasound.
That means rather not.
Exactly. And that's perhaps another important point. When you're investigating a suspected GIST or monitoring its progression, an ultrasound isn't the method of choice. However, it can certainly help with surgical planning in the stomach area to precisely determine where is the tumor located, how large is it exactly. But a CT or MRI is certainly the much better examination and also clearly recommended in the guideline not to use ultrasound.
Yeah, exactly. I was actually just about to get to that point. But often, to even get a CT or MRI, you first need a reason why it's necessary. And what's more, the waiting times we have now are really long. That means it's often an incidental finding. And once that's found, the next step is indeed the correct imaging. And what is then more appropriate, rather MRI or CT scan?
There's not a fixed recommendation. Both options are good. What's extremely important, though, is that in this particular instance, this entire area is genuinely covered. Ultimately, we always require an image that fully visualizes the entire liver, including the diaphragm with a portion of the lung, and the very beginning of the esophagus. And then, truly, all the way down to the exit point, which is the anus, everything must be captured, because that's the area where a GIST can be present, and where it can have spread. That means a CT or MRI of the abdomen and pelvis. The MRI is a bit more precise concerning the liver. The CT is a bit more precise regarding the intestinal loops, because the bowel moves, and therefore in the MRI it's always slightly blurred, because it simply takes longer. But both examinations are equally good, and if I get the CT 3 weeks earlier, then please choose the CT. And with contrast medium. That is the next important point. Please, not just native, but always with contrast medium. And the experience that I also get reflected back is, with the help of this platform, through which you can get appointments, with the help of the urgency code, it's often the case that if you actually have to put in work, but mostly you still have the chance to get imaging in a timely manner. And I believe that investing this time is always worth it, even from a purely psychological perspective.
Yes, exactly. Very important point. And now, a stupid question. In the blood count, do you see anything?
Usually not. So if the tumor has connected to the gastrointestinal tract, if bleeding occurs, which can sometimes be hidden because it only seeps and you might not see it in the stool, which can turn black if there's blood, there's no way to detect a GIST in the blood, neither in the blood count nor in the organ values, unless we have an advanced disease where liver function may have already deteriorated, or we have an anemia, meaning a significant drop in hemoglobin levels. But at that point, one usually already has other symptoms that are indicative. There are no tumor markers for GIST, not yet. There's research showing these KIT mutations are detected in the blood, but at the current time, it's not a routine practice.
You just spoke about a KIT mutation. What exactly is that?
Our cells in the body are in constant exchange with each other, and for this purpose, on the surface of the cell, we have protein structures where a signaling substance from the outside can bind, and the cell then performs an action in response to this binding. For example, on the surface, we find structures, receptors like KIT or the PDGF receptor alpha, which, when they are activated, instruct the cell to grow and to divide. Now, with GIST, in 90% of cases, there are genetic changes in one of these two surface proteins that change this protein so that no signaling molecule needs to bind to it from the outside. But these receptors, proteins, are permanently active and tell the cell, grow and divide. This causes the tumor to form. To put it simply, there are often still other things that also play a role, but ultimately, that is what's important.
In our body, it's important that cells divide, right? Because we're constantly losing cells and so on and so forth. In a healthy case, there are, so to speak, signaling substances that say, something's broken, please repair it now. And now, in this particular case, nothing broke. Nobody says, please repair. But the thing grows all on its own, right? Is that right? Can you put it that way?
Right.
Okay, good.
Exactly. So, in principle, it's that simple. So these genetic changes are happening constantly. Every single second, with every snap, hundreds to thousands of them occur, but the body recognizes and then repairs it. But in some cases, it's simply not recognized, and then a cancerous tumor can develop from it. And that's why this GIST disease is so special, because we've recognized its cause, and because we can intervene right there with a drug or drugs that go and take away the energy from this receptor, this protein. That means medications essentially go to the exact spot where the energy normally binds, and then they block this grow and divide signal. And therefore, a GIST stops growing with these medications, and ideally, cells also die off. This is essentially the only treatment option that we have for patients with GIST.
And it's effective, right?
It is effective. It depends on where the genetic alteration is located and if it's even present. Keyword, mutation analysis, which will also come up later. So we need to know, is this alteration present? Because only then, and only with specific alterations, can these medications work. That's why we need to analyze it precisely. And if they work, they usually work well. So, there's a good chance the tumors will shrink, and then we can treat them quite differently. Right? Because they don't just get smaller, they also change in their structure. They become less vascularized, they get firmer, and for example, they're then more easily accessible for surgery. There are many beneficial effects from these medication treatments at any stage.
Okay, that's really good news. Does that actually mean that the immune system can then clear away the remaining tumor? Or how does that work?
So, once the cell has died, the immune system usually takes care of the rest. Otherwise, if we're considering, for instance, immunotherapy, we unfortunately know that GISTs aren't very attractive to immune cells, at least most subtypes. So, therapies like immunotherapy haven't brought the desired success in studies so far, but we do have our tyrosine kinase inhibitors, which work all the better.
Okay, so that's truly a very complicated word. I believe we'll really delve into that in detail on another occasion. Now we've done a bit of a fast forward and have already found ourselves in therapy. But perhaps we should still take a moment to look at who typically develops GIST? What kind of, so age structure, gender distribution? What's that typically like?
So, there is a clear increase in the incidence of the disease that begins to show from about the age of 60. And the largest group of patients who actually develop it is typically found among people who are roughly 70 years old. These tumors are very rare, even at a younger age. Around the 30th, 40th year of life, there's another instance. You can't call it a peak. They're truly few. These are then other forms of GIST. So, in this age group, we need to take a closer look. You often don't find the KIT mutation or PDGF receptor alpha mutation there. Instead, this condition is often linked to hereditary tumor diseases with a loss of succinate dehydrogenase, also a very complex word, or in neurofibromatosis type 1. These are then specific other subspecies.
Now you mentioned that it tends to occur in older people, but GIST also appears in younger individuals on occasion. Is there sometimes a familial connection? Does something like that exist?
Actually, yes. So, at a younger age, these diseases are usually somewhat different, so there are still patients who develop KIT, or PDGF receptor alpha mutations. It may be the case that these changes are not only found in the tumor cells, but if you now look at the blood of the patients, also in healthy cells. And when you then ask about the family history, you find that maybe other family members have already been diagnosed with GIST. And in this case, we're talking about a familial GIST syndrome. This means a genetic alteration that causes one to develop GIST sooner and also develop multiple GIST throughout one's life.
Just briefly, mutation, what is it? Why do mutations occur? And what's its connection to cancer, sarcomas, and the like?
So, a mutation means that in our genetic material, which is essentially the blueprint for our cells, a change occurs. This means we have this blueprint. It is read, and from this, a protein is produced. And if something is suddenly different in that blueprint, then that causes the protein that results from it to change. Exactly, that is the problem in GIST. Let's go back real quick. We have this genetic alteration. This genetic alteration modifies these surfaces, this protein, in such a way that it no longer requires a signaling molecule for this receptor, this protein, to become active and instruct the cell. Grow and divide. This means it only needs the energy. It still needs that. But then we have a mutation in KIT, or PDGF receptor alpha in certain locations. These are the exons that you know from the pathology report. And that then ensures this constantly active signal is present. That's how the tumor develops. So that means we have this active receptor. This means, due to this genetic alteration, it permanently sends the signal to the cell. Grow and divide. But it needs energy for that. And at this point, we can intervene with medication. Using tyrosine kinase inhibitors like imatinib, the standard, first approved drug for GIST, which acts precisely where energy binds, preventing it from binding. This means the signal stops because the energy supply is cut off. That's essentially it.
Like someone pulled the plug.
They pulled the plug, exactly. The problem is that imatinib can only bind there in very specific situations, and that is actually like a key and lock principle. This means only if I have certain genetic changes does imatinib fit at this particular spot. If I don't have this specific change, then the imatinib goes away again, and the energy can bind once more.
We've already talked a lot about the disease itself, and also the mechanisms that lead to this condition. But one important question would be, for many cancers, there's a kind of staging system. How is that with GIST? Are there stages for it? Or how do you even talk about it?
So, in principle, there's this staging system, often used for carcinomas or other tumor entities, following UICC stage 1 to 4. This can be done with gastrointestinal stromal tumors, but it provides no information about how long one can ultimately live with the disease. Therefore, we don't use this classification at all.
Oh, right.
Instead, we classify patients based on their risk of relapse. So, for patients with a localized disease, meaning only one organ is affected, for example, the stomach or the intestine, there are specific risk factors. One such risk factor is, where exactly is my tumor located? Stomach or small intestine? Is that located in the rectum? So, how big is it actually? And how quickly does it divide? So, how fast is this tumor growing? And for that, we need to know the mitosis counts. That means the nuclear division figures a pathologist can examine under the microscope. It is highly standardized and absolutely essential to be included in every pathology report. And should a tumor have already been removed, which frequently happens before patients come to us for consultation, I need to know, has the tumor been completely resected? If that is the case, what was the precise surgical safety margin? And was he injured during the operation itself? So, was there a rupture? Or did the tumor actually arrive completely in pathology, without any damage to its outer surface? And these are the crucial things, for which I need a surgical report and a pathology report. And when I have all this information, it is possible to derive a statistical relapse risk. Yes, there are tables, but there are also wonderful contour diagrams that we prefer to use. And then we could tell our patients their relapse risk, if they do nothing now, would be XY%. And that also determines if an adjuvant therapy with imatinib is used or not.
And if we just take a very quick look, we'll really go into detail about the therapy later, but let's just take a quick look now. So, chemotherapy or anything like that isn't even an option, right?
So chemotherapy is completely ineffective for GIST. So that's something we can establish, and it's what people despaired over before these new medications. And, unfortunately, it's still deeply rooted in some doctors' minds that GIST can't be treated with medication, meaning they always have to operate, and as quickly as possible, so remove the primary tumor fast, and whenever metastases appear, please operate immediately. This is something that, unfortunately, we still sometimes observe in our patients, and yet it is completely avoidable if one simply speaks with an expert beforehand.
So we're back to sarcoma centers, GIST experts. It's crucial to really go to the right people, you know?
This is essential for the quality of life. For example, you would operate on a stomach cancer with a complete stomach removal. whereas a GIST really only needs to be minimally removed, if it's feasible, right?
So the meds are effective then? Can you fix it with meds again?
Well, you can't fix a poor surgery with medication, but given the growth pattern of a GIST, we know that many cells aren't scattered in the surrounding tissue. This means you don't need to remove this tumor with a 2, 3, or 4 centimeter safety margin, but we know from analyses that it's entirely sufficient to remove the tumor macroscopically. That means the surgeon must state that he or she has completely removed the tumor. That is what is important. Whether it extends into the margin, according to the pathologist, that's probably not that important for the prognosis, for survival, but what's important is that it was completely removed and that it didn't rupture during the operation. Those are the things that are important.
I believe, since we were just on the topic of how important it is to see a GIST expert, I think it's also important to emphasize that generally, or perhaps correct me, GIST is not an emergency, right? That means if I now suspect GIST, I actually have the time to look around and inform myself where I can truly find a suitable expert.
So, if I don't currently have a life-threatening hemorrhage due to my tumor, if I don't have a bowel obstruction caused by my tumor that requires immediate resolution, then that is definitely not an emergency situation. And then it's always the right thing to do, to go to a place where doctors work who are very familiar with this particular disease. It's not just oncology, but also the surgeons who would perform the procedure, and the radiologists who can better assess tumor extent and also how therapy has responded. That's a completely different field that we won't explicitly touch on now, but also pathology, which can assess, is this really a GIST? I can do that as an oncologist, too. I read through the report, and if some markers are missing, I become suspicious. And then it can be very likely that a reference pathology says, no, that's not a GIST at all. And the patients might have already taken imatinib. So it's extremely important that this condition is diagnosed by experienced doctors and that treatment decisions are also made by experienced teams. And continued treatment with medication can absolutely be carried out without any problems by local, resident doctors. That is absolutely not the question. In case of complications or side effects, you can return to the center. But treatment decisions at the beginning and every treatment decision thereafter should always take place where the expertise lies, and where, for example, clinical studies are also conducted. Because we have more and more clinical studies in early lines of therapy, but we're not reaching the patients, which is really very unfortunate.
Yes, I see. So what's the outlook now? We've discussed diagnosis and therapy a bit. What's the quality of life like now for a GIST patient? Can you live quite well with it, or?
We have many patients who, even with metastatic disease, are able to continue living their lives quite normally, who can pursue their professional careers, who can fulfill their family responsibilities, with good side effect management, with good psychosocial support, and for years they can live their lives well, even with metastatic disease. And that is simply the goal of the therapy, to achieve that particular thing.
That's what's so wonderful. I mean, we just spoke a little while ago, and it all sounded so complicated. And it is complicated, but that's actually the amazing thing, isn't it? That researchers like you have understood so well how this disease functions, that one can truly intervene precisely there with the key and lock principle. That one can stop this disease right where its original onset was, right? I believe that's what's so great today, in the era we live in, isn't it? That we have made such advancements in therapy. You had just mentioned earlier that chemotherapy simply doesn't work at all, right? So thankfully, we now have these new therapies.
That's absolutely true. And regarding these medications that are approved, of which there are now 5 for GIST, we have further studies with new, very promising medications. But we've also gained more and more understanding that we can treat patients with local therapies. So, also radiation. It used to be said that GISTs are totally radio-resistant. That's not true at all, you know? So you can offer radiation, especially if problems arise somewhere. You can identify the spots where a tumor might be growing, while everything else is stable, and say, okay, we'll target that exact spot now, perform surgery or radiation or another therapy, remove it, and then we can stay on the medication. So there are increasingly more insights in the holistic therapy of patients with GIST, but then we come back to the issue with the center. So that belongs back in the places where people actually have that experience.
Thank you very much indeed. Thank you for this comprehensive overview we have now received. We have delved deep into the mechanics, into the functionality of GIST. But I think it was really valuable that we allowed ourselves this time. Dear Dr. Falkenhorst, thank you very much for your time, and I especially wish you continued success in research, because I believe that is exactly what moves us forward.
Thank you for your time.